So as I said, the first part I'll focus mainly on living donor liver transplantation, and second half talk about acute liver failure. The beginning years in India in 1994, liver transplantation was attempted with variable results in many hospitals. And 2001, our group did our first liver transplantation in Sir Gangaram Hospital, and subsequently this became India's first successful liver transplant program. Since then, the Indian transplant community has been very sort of supportive programs around the region, and we've helped establish living donor liver transplantation in surrounding countries, including cooperation with Pakistan in liver transplantation. So how has this amazing feat happened in a country which is not so, it's a relatively poor country and a high technology, high cost procedure? First of all, right in the beginning, we started doing recipient hepatectomies without veno-veno bypass. We developed an algorithm for anterior sector drainage in right lobe grafts, introduced a technique of middle vein reconstruction using explanted portal vein conduits, established that right hepatic artery anastomosis using loops was as good as suturing under the microscope. So that's, you can see here, a recipient hepatectomy with cava preservation. Side by side, there were changes in practice. The control of infection was far more important than control of rejection. Established protocols for donor safety. We realized that bloodless surgery was not possible, but certainly we could do less bloody operations. Chose selection of patients in a way that it was not too late and not too early. And of course, all through these years, we've emphasized on cost reduction. And one of the important factors of cost reduction has been eliminating technical complications, decreasing blood loss, and Dr. Manav, who's chairing this session, published that CMV prophylaxis is not needed in our recipients in liver transplantation 2012 this year. Of course, you need to optimize the pre-transplant status in living donor liver transplantation. You have this advantage. We also realized that experience was accruing. There was less use of diagnostic tests. Biopsies were infrequent, mostly protocol biopsies for hepatitis C. Showed that hepatitis B immunoglobulin prophylaxis was not necessary. We avoided induction agents. And as a result, a liver transplantation can be done for as little as 19 lakhs in our center and 15 lakhs for pediatric patients. There's been a mushrooming of centers all over the country, rightly so. There are, I think, at the moment, 20 centers and another 20 licensed and ready to start soon. Over 800 transplants every year and about 100 cadaveric transplants, and the success rate is around 90%. At our own hospital, we've done over 1,000 transplants now. 2011, we did 237 transplants. 2012, we did 289 transplants. And altogether, we've done 93 pediatric transplants, and our one-year survival is 89%. We looked at a cohort of patients who died after operation. As you can see, only 12 out of these 57 we studied died from a technical reason. Most others, the reasons were non-technical. So we've come a long way in doing this operation in our country. So how has this happened? There's improvement in imaging, improvement in anesthesia, improvement in surgical technique, and improvement in post-operative care. This is the kind of pictures you can get nowadays for hepatic veins, portal vein, bile duct. You can calculate the volume, and you can use the intraoperative Doppler to correct any anastomosis that is not right. Right lobe liver transplantation has changed the face of transplantation. This procedure theoretically is now available to any patient with decompensated cirrhosis and those with acute liver failure. However, as right hepatectomy is a major operation, training in donor surgery is essential. So much so that we have patients who are disadvantaged from the MELD scoring system of allocation, that we have American people coming to us for transplantation. To get your right lobe LDLT right, you have to select your donors carefully, 18 to 50 years of age, compatible blood group. Transplant across blood groups can be done in young children and in those with fulminant hepatic failure. We haven't done that so far, but certainly I'll have a slide on this for fulminant hepatic failure. Non-fatty livers and at least 30% remnant. We've emphasized all throughout that donor safety must be maintained. Donors are healthy individuals. Right lobe donation is a complication. There's no getting away from that. So what we look at is deviation from the course of recovery. And this work was done by Dr. Ramdeep Ray, one of our colleagues, and he looked at 5,540 cases, and 92% had no deviation from the expected course in our center. And this is a detailed analysis of this. 458 had uneventful recovery. I think one of the keys is, of course, getting your cholangiogram right, both in the both prior to transection and after bile duct division. So there's a big dilemma in right lobe transplantation. The liver has 2 lobes and 3 veins. So what do you do with the middle hepatic vein? Take it with the recipient, donor may be harmed. Leave it with the donor, segments 5 and 8 may not work well. And so we devised a clamp test that tells you how much of the anterior sector is sort of being drained by the middle hepatic vein, and use this to retrieve the middle hepatic vein in the graft or reconstruct. And that's CUSA for transection, then the right lobe graft after perfusion. And this is what we do in most of our donors now. This is segment 5 and segment 8 vein, and this is explanted conduit from the portal vein for reconstruction, because as you know, we don't have access to cadaveric grafts. Interestingly, one of the phenomena that have affected liver transplantation is right lobe LDLT has been small foci syndrome. And therefore, we believe that a triphasic outflow is must for this. Of course, we also looked at portal pressure measurements, and there is and whether you need to do inflow modulation or not. At the moment, we're not doing any inflow modulation based on the portal pressure at the time of surgery, but leave it later if the patient is not doing well. So we looked at our data for patients who were more than 100 kgs of weight, and what was the outcome in them using a single lobe graft. And if this is details of the, and you can see the average graft recipient body weight ratio is 0.7, and in some it was as low as 0.52. Interestingly, and of course the operative time was of course long, blood transfusions, but the two groups between less 100 kg were compared and were similar. Interestingly, in this group, our 3-month mortality, perhaps this was a very carefully selected patient, but in this group, the 3-month mortality was 0. And one of the ways we believe that you can eliminate small foci syndrome is that if you can free the suprahepatic cava completely at the top, so that you can make a nice right hepatic vein anastomosis. Biliary anastomosis has been the Achilles heel of living donor liver transplantation. Duct-to-duct anastomosis is the normal method. So what we started doing recently is that the right hepatic artery we joined to the left hepatic artery, leaving the entire biliodigestive sheet intact. And that's a picture of here. You can see the bile duct completely with its arterial supply, and there's a temporary portocaval shunt. And although the follow-up is short, but it seems that the group which had the left hepatic artery anastomosis had a the left hepatic group had a lower stricture rate. The leaks were similar. Now moving on to the second part of my topic, which is acute liver failure. The extent of the problem is huge, as you all hepatologists and everyone here knows this. But I looked at some of the sort of data from India, and Dr. Charya has reported that 193 out of 413 cases were viral hepatitis. Dr. Damon said that in one of his papers that 186 out of 204 had viral etiology. And a multi-speciality hospital will see about 50 to 80 cases of acute liver failure annually. And the published mortality rate is over 60%, though in one of Dr. Charya's recent paper, the mortality was only 47%. If you look at results of liver transplant, disease donor liver transplantation, it's about 70%. There's an initial drop in perioperative, high perioperative mortality, but subsequently the results get better. Disease donor transplant results around 70%, somewhat inferior to elective transplants, but LDLT seems to give better results. And I'm not sure why that is so. Is it patient selection? Is the timing of operation better? And not only us, and Dr. Soin also showed this, and Dr. Sehgal also talked about this, and Trotter looked at the data from the A2LL cohort, and the 1-year survival in LDLT was better. I'm not going into the types of operation for acute liver failure, but mainly it's orthotopic liver transplantation. We tried auxiliary liver transplantation in one patient, but that didn't do too well because of the toxic liver syndrome. So there are different types of hyperacute liver, types of acute liver failure that we've seen. It's important here to just to sort of give understanding based on our experience how we deal with them. So this you have hyperacute liver failure, and here I think one of the important lessons we learned quite early on was to separate things like dengue and leptospirosis. You have acute liver failure and you have acute and chronic liver disease. Quite often we have acute and chronic liver disease as presentation as fulminant liver failure, and we'll do a CT scan quite early on to differentiate this. This is a young child with hepatitis A, healthy male, it's a serial observation, and the INR improved, and this was discharged. So what we learned from this, that observation showed improvement. So in living donor liver transplantation, you have the big advantage that you don't need, you're following the patient, and you don't actually need to list, you don't have to wait for an organ, you can do it once the patient, when it's quite clear that the person is not improving. The donor had been worked up, authorization obtained. And one of the problems that we faced in this group is, in fact, which is what Dr. Rela was alluding to, is that if they can have very severe ARDS and ETN, and the transplant cannot be considered. Late issues, what we've learned from this group is even they may recover from encephalopathy, but then later have infection, and perhaps the necrotic liver is a nidus for fungal infection or viral infection, and many of them, even if they recover from encephalopathy, don't do well later on. And talking to Dr. Charya and others, they also seem to have a similar experience. Acute liver failure, this is a 24-year-old lady, pregnant lady, who had 4 weeks encephalopathy after 4 weeks, emergency living donor transplantation from husband, and that was based on decision based on grade 4 encephalopathy. Fetus remained viable. We had a very, very worrying time. 3 weeks after the husband had donated, he developed jaundice, and we realized that he also had HEPI infection. So important thing we learned here was that if you have deepening encephalopathy, it's a poor prognosis. Fetus can remain viable, unlike what you can read in different sort of reports on hepatitis C. Viral illness can affect more than one family member, and this becomes important in living-related liver transplantation because the members are from the same family. Also, there's quite a high sort of chances of false negative results for HEPI serology, and HEPI RNA is not easily available. We had taken a clinical vignette of a subacute hepatic failure, 55-year-old male, jaundice for 2 months, mild encephalopathy, development of respiratory distress and renal failure, history of Ayurvedic medication, all markers were negative, sort of semi-emergency living donor transplant from son, well, needed stenting at 6 months. So we learned that in this group who have a kind of slow indolent course of jaundice, in them even minor encephalopathy is important because they don't do well and they should be transplanted quickly. Post-viral colitis is different as the INR is preserved. The ultrasound may show small liver and collaterals may develop as early as 2 months. And one of our fellows, Dr. Singhal, showed that if they have more than 70% hepatocyte necrosis, then transplant becomes necessary. Another clinical vignette on acute and chronic liver disease, and Dr. Mana will remember all these cases quite clearly. This is from our experience. 12-year-old girl presented with high bilirubin, raised INR, features of hemolysis, ascites, no encephalopathy, low serum ceruloplasmin, raised 24-hour unicopic excretion. CT scan showed a cirrhotic liver. This we treated with DPEN and zinc, and there's gradual improvement with disappearance of ascites. Quite often living in north of India, alcohol is a big problem. So I had this 30-year-old dentist with heavy daily consumption of alcohol, deep jaundice, renal impairment, raised INR, altered sensorium, pulmonary infiltrates. Family is very keen for transplantation. The ultrasound showed a huge liver ascites, and the dilemma was to transplant or not to transplant. Post-transplant, there was uneventful recovery. Subsequently, of course, our stand has been validated by Mathurian's paper in NEJM, and I think living donor liver transplantation in the end is quite often a family decision, and we cannot be judgmental on whether they should have or not. To wait may make them completely untransplantable, and to transplant, of course, you run the risk of recidivism. My colleague, Dr. Taneja, looked at the alcoholic liver disease series. Between 2007 to 2011, there were 117 transplants for alcoholic liver disease. 25 had alcoholic hepatitis. The MADRI differential score was 92. They followed up for 35 months. And overall mortality is very high in this group, 32%. Alcoholic liver disease tends to do badly after liver transplantation. And the risk of recidivism in those who were abstinent versus those with alcoholic steatohepatitis was not significant. The pre-transplant management in our center is similar to what you've been hearing, except I just wanted to put in this slide that we do not do intracranial pressure monitoring. We, of course, record pupillary reaction every hour, mannitol if suspicion of raised ICP, CT scan prior to starting a case in OT, and quick hepatectomy and portocaval shunt. Crucial question is who to operate and will the operation be futile? And we suggest to all people who get in touch with us with fulminant hepatic failure that they should perhaps be sent to a liver unit if the INR is greater than 2. Now, we heard Dr. Soin talking about listing in LDLT programs. I'm not quite sure what the listing is for in this group. All prognostic models have a low negative predictive value. Patients will die in spite of favorable prognostic features. Grade 3 or 4 HE or cerebral edema and has over 90% mortality. And living donor liver transplantation, one can intervene at the appropriate time. So what do? So we look at their INR over 72 hours without FFP support. If there's onset of cerebral edema, pupillary asymmetry, fits or decerebration, grade 3 or 4 encephalopathy with onset of another organ failure, and then they will have a transplant. Whereas in the hyperacute failure, the INR is greater than 6.5. Many of them will recover, but we've learned bitter lesson that if they have an additional organ failure, then perhaps they should have an early transplant rather than waiting for them to recover. And in children, if the INR is greater than 4, with or without encephalopathy. So when not to operate, hypotension, non-liver sepsis, we ignore the high TLC because most of them have a necrotic liver and will have a high TLC count anyways. ARDS, established renal failure, and that's one of the reasons why we don't have so much renal support in our series of acute liver failure, or pupils have been fixed dilated for hours. So we'll show you now data for acute liver failure. Between 2006 to 2012, 918 transplants, 49 had acute liver failure, 39 were adults and 10 were children. Interestingly, and it is quite similar to Dr. Sehgal and Dr. Soin's data, over half of our patients had a non-viral, about 1/3 of our patients had non-viral etiology, and only about 1/3 had established viral etiology, which is quite different from what has been reported previously. All underwent living-related liver transplantation. One had auxiliary transplant with not so good result. So we stopped doing that. Follow-up was for 32 months, and survival was 87%, and most patients died from sepsis. Morbidity, as you can see here, a lot of bile leaks and strictures, and I think in the acute liver, in the fulminant hepatic failure, biliary complications are probably more than the rest of the population. What about ABO incompatibility? There may be a role, although we haven't done that, but there's a legal requirement for a near relative to donate. Donors are between 18 to 50 years of age. Pair exchange is cumbersome because you need to get clearance from many committees, and in acute liver failure, you need to act within hours. So perhaps there may be a role for ABO incompatible transplant in acute liver failure. Surgical issues, middle of the night operation, donor operation is routine, can be completed after recipient hepatectomy because obviously after the recipient you can stabilize the patient, takes much less time, and we aim for a graft recipient body weight ratio of 0.8%. So there is no portal hypertension in the recipients. Bowel gets congested, so we almost always will do a shunt and routine implantation. Some post-operative issues. What we stop as we don't intervene for raised ICP post-transplant. We find that it corrects quite quickly after the operation. There's usually have delayed extubation, and occasionally we'll consider elective tracheostomy for suctioning. And regaining of consciousness can be very delayed. And in fact, one of our pediatric recipients recovered after 10 days. Immunosuppression, low dose, none for 24 to 48 hours, tacrolimus, mycophenolate, and cover with antifungals. The late issues with acute liver failure, they may often need psychological support. Unlike chronic liver disease, they've never been unwell, the major and evil, and difficult to come to terms with lifelong immunosuppression. So in conclusion, living donor liver transplantation for acute liver failure is very feasible. Timing of operation can be accurate and need-based. There's difficulty in motivating and working up a suitable donor because the family just cannot accept the fact that there's somebody who's ill and another one has to undergo a major operation. And I think there's a tendency for a higher rate of biliary complications in acute liver failure, transplant for acute liver failure. Thank you.
Thank you, Subash. Have I understood right that you don't necessarily, you're not using, for example, like the Medanta group, Soin said he uses
King's College. No.
So you go by a clinical course of...
And many people who do living donor, if you look at the Japanese literature, you find they do the same thing.
Yeah, I mean, that's quite acceptable. I was just wondering, is there any value... I mean, you've got a big experience of the numbers who did well, did not do well using these criteria. Have we got any, data which you can generate to compare with?
I think if you
these
ask any
colleges?
hepatologist or intensivist,
makes
he'll
sense
tell
what you're
you,
doing.
whether the patient is going to survive or not from acute liver failure.
No, I think it makes sense. I can understand the logic behind it. I'm just wondering because you've got a lot of patients, you should.
Maybe Dr. Manav should do it. I'm just a surgeon.
So maybe, see, we have had patients who came to us with INR of 7.5, with no other organ involvement and grade 2 encephalopathy.
Yeah, I remember two patients like that, recovered.
Both of them recovered. What we do now, as Dr. Gupta has very clearly told, what we do now is we serially monitor their INRs, bilirubin and sensorium status. The absolute indication is only one. INR more than 6.5 with one organ failure.
One other organ failure.
One other organ failure in addition to liver. If that is there, then we straight away ask for transplant. Otherwise, there is no straight indication for transplant at our unit. That's what we have seen over a period of years. Dr. Ella, please.
You're all simplifying the art of acute liver failure. But what you need to say in that, you said INR of greater than 6.5 with another organ failure, usually perhaps kidney, but kidneys you don't transplant.
No. Not established renal failure.
We only don't transplant.
If they get on dialysis for 3 days, we won't transplant them. They do very poorly.
Sir, the definition of acute liver failure includes encephalopathy, so that goes by default.
Because the example that you quoted, an INR of 7 with no other system failure, recovered spontaneously, wouldn't have had encephalopathy.
Yes, with encephalopathy. There's no.
Yes, obviously with encephalopathy, sir.
No. We're not talking about patients of subacute failure who are completely okay. This we've seen. We have two patients. In fact, we went by the King's College criteria, and I was pressurizing in the beginning years that he should have a transplant with INRs greater than 6.5. And our physicians were resisting. And in fact, it was a daughter of a dermatologist from Delhi, and she improved.
What grade of encephalopathy was that?
Grade 2.
They improved. It's not something that we've seen that.
No, everybody's seen that. In King's College Hospital criteria, the mortality of King's College Hospital criteria is 90%. So there are 10% of the patients who would survive.
Yeah.
I'm not saying if they fulfill King's College Hospital criteria,
So,
they have to die.
so what we're saying is that if you follow them up closely, you'll know whether they are getting better or they need a transplant or not. And I've talked to some Japanese groups as well, and they seem to follow the same sort of.
But my worry is your indication is very woolly. You understand what I'm saying? It's very soft.
See,
We know when to transplant, but we can't tell you when it is. That's what is worrying for me.
Yeah, maybe we should use some other scientific method like factor 5 or something.
Let me put it this way. A patient who comes to you after a horrid transfer from a peripheral center, he's dehydrated, he's often not given adequate, anyway not managed properly. You try to stabilize this patient over next 24 hours. His parameters are going to change. That's what we've seen. A patient who comes to you straight away, the exact parameters he reports to the hospital are not the actual parameters.
Yeah, I think there's a problem with Apollo INR. It's always lower than the periphery INR for some reason.
Can I make?
Second.
I actually agree with Mohammed that see, at the end of the day, Manav, I agree with what you're telling. We have discussed, we work together. We also agree with the same thing. But end of the day, in a procedure of this intent, there have to be some objective criteria.
It is very objective,
Okay.
by the way.
And
you missed all the.
See, if you actually, listen to the latest talk by Dr. Acharya and this thing following this ALF-ED model, because we don't see patients on day 1 and day 3. They often come to us on day 3, day 4 directly, so we cannot apply that model. But there has to be a model which is suitable to our setup and which we have to actually define and start using. Now, why we use King's College is because we don't have any alternative model which is so good as of now, which actually allow. Otherwise, if we just go on our clinical judgment, that may actually,
I think it's not perhaps you didn't get the message right, but the indications are very clear. We transplant when it's clear
So
to
you
all
have
of
a
us.
criteria. No, so you
we
have
are
a
clear to
criteria
us
or
the patient will not do well. after, on conservative it's a bit like bleeding. You can carry on watching that the person is bleeding, but you know that if you wait longer, he's going to die. I mean, great for cerebral edema, great worsening encephalopathy. I mean, it's quite decerebrating. So we know that we've saved many patients from transplant following this approach. In fact, the girl Wilson was listed for transplantation in another place.
The problem with King's College, which actually we all agree, is that it is not 100%. It has got good sensitivity, but if fulfill the criteria, that is fine. But non-fulfillment of KCH does not predict survival. We all know that. So that is a basic flaw. So I think we all agree with what you're telling, but I think we should have our own some sort of criteria which we start using in our Indian setup, and then we should probably have more strength in our.
But the dynamic model, and Acharya has actually shown it very nicely, is probably the best way.
What do with this alcoholic hepatitis and autoimmune hepatitis who are on steroids? You wait for some time, or you directly go for the transplant, or do you add some antifungals or something prior to the transplant?
Currently, I think in the past we've been very against use of steroids for alcoholic hepatitis. But I think now we will have to do it, because Mathurian has said that you should only transplant if they failed a trial of steroid therapy. But in the past, our group has been very against use of steroids in alcoholic steatohepatitis. But the majority we've transplanted have actually received steroids. I think it makes them worse. I don't know, the hepatologists will answer this question, whether it's actually of any use or not. I think it makes them worsens the condition a great deal.
I think Dr. Dhiman will remember there was a talk this ISG last month by Dr. Duseja. He collected data from all over India regarding use of steroids in alcoholic hepatitis. And I think except one center, every single center, he collected data from 15 centers, said they're not using steroids for alcoholic hepatitis for the risk of infection. The patients who actually benefit with steroids is a very small number, and those who worsen with steroids are much more. So,
and also don't look for ANA, because ANA is always positive in these patients, and don't give steroids because ANA is positive. Isn't it, Dr. Manav?
Yeah, that's right.
If I just add one line, I had this, debate which Professor Rela told me to, speak in favor of, transplant hepatitis. Now, the Mathurian paper, the basic problem is, it is a 7-year collection of, patients, and they have done 28 transplants in that period. It's a very highly super selective group of patients, and we all know that. We also know actually in favor of doing it in selected group, but because it's a very, during that time, they had at least 1,000+ listing for other causes. So ultimately, the guys who are getting steroids are very small. I totally agree with you. On a practical clinical practice, it is not possible.
That's right.
That's a great talk, Dr. Gupta. Thanks a lot.
Thank you.